Let me say one thing here, that when we started the journey of quality in India, I will say formal journey, which is the year 2005 and 2006, we actually that time were thinking that the USA, which is started the first country in 1951, and we started in 2006, almost 55 years late. But over the years, we have been saying that India may start late, but it catches up very fast. In fact, today, we have more than 20,000 hospitals and nursing homes accredited or certified for the quality. I think that is the pace which we are going. Let me also tell you here that we learned in the initial phase from the three leading countries, that was USA, Canada, and Australia. But in this journey of 55 years, we have also helped countries like Nepal, Sri Lanka, Iran, even Pakistan, Oman, UAE, from our learning. So I think today's session is, again, transforming the quality through collaboration. And that is where we have got three distinguished speakers who will be sharing their thoughts about the collaboration and how do we learn from each other. Thank you very much to the opening session.
Good morning, CAHOCON colleagues. Good morning, India. And good morning, international guests and fellow distinguished speakers. I'm Geoffrey Braithwaite. I'm from ISQA, the International Society for Quality, and also from the Australian Institute of Health Innovation in Sydney, Australia. So, we're going to talk collectively on the theme of CAHOCON, which is collaboration and continuous improvement in a journey, as you said. So let me add some context to that by speaking about the international experience. So I'm from the Australian Institute of Health Innovation. That's a large research group in Sydney, Australia, and we do health systems research, shining a light on quality and safety activities across the world. So we have a number of research centres. And why I say all of this is, if you are interested in a research evidence base to your work, you can go to our website, and there are many articles, papers, chapters in books that are free downloads for you to help with your work, with your own journey in quality and safety. So here is a hello from some of our team at the Australian Institute of Health Innovation in Sydney, Australia. So, two countries very dear to my heart are India and Australia. Now, we won't talk about cricket, but look at the context of both countries. India is 1.4 billion people, and in Australia we only have 27 million. We have a bigger GDP per capita because we're more a developed country in Australia, but India has this rich diversity of quality and safety activities that really the rest of the world can learn from. And we've been talking about that, have we not, colleagues, at a pre-conference workshop. So before I go much further, though, I'd like to tap into you. How do you feel about the future of healthcare? So the proposition I want to put to you is we will have a better, safer health system by 2030. Who strongly agrees with that statement? Who's more likely to disagree or strongly disagree with that statement? Some people over here, I'll talk to you in the break. We'll have a chat. And who's in the middle? Who's more neutral? So I can see in this room we have a mix of optimism and pessimism about the future of healthcare. Maybe that's about realism versus what we hope to achieve with the health system. Let me talk about that health system then, and let me talk about quality and safety by way of helping you with your journey of improvement. So modern health systems can be captured by these three numbers on a paper we published only 5 years ago: 60, 30, 10. In modern health systems, where we have measured at the systems level, about 60% of care is in line with level 1 evidence or consensus-based guidelines, the guidelines that the clinicians say are important in delivering care. About 30% is some sort of waste, test results that don't get seen, or care that's provided that really doesn't have a net benefit to the patient, or bureaucracy that gets in the way of delivering value-based care. So 60% high-quality care, 30% waste, 10% harm, misadventure, complications, adverse events. So 60, 30, 10 are the measurement at the systems level of modern health systems. 60% of care delivered in line with level 1 evidence or guidelines, 30% is some form of waste that does not add value to patient care, and 10% adverse events or complications. Those numbers seem to recur in health systems wherever they have been measured. So the question for India and the question for your health system is, can you beat those numbers? Because if you can, more 60%, less 30%, less 10%, you'll have better healthcare for your patients. You don't need any other indicators of measurement. But these numbers seem to have flatlined for about 20 years, and we're very worried that we have trouble making them improve. And as well, on that 10%, harm costs a lot of money. And it impedes economic growth, not only in India but elsewhere, because we have to spend money on harmful care to redo the care for patients. That's not very good quality. I don't mean to say that healthcare is bad, though. I don't mean to say that I'm sending a report card to the health system in India, Australia, and elsewhere that it's bad, because we've been enormously successful in medicine for years, decades. We can do heart bypasses on 80-year-olds, keyhole surgery, look at AI and genomics, treatment for HIV, AIDS, COVID-19 vaccinations. And you will have your own examples. So what have people advanced as solutions for the kind of problems that 60-30-10 represents? That's the next interesting question for you in your quality improvement journey. So people have come up with all sorts of solutions, have they not, co-chairs? They've come up with all sorts of solutions: root cause analysis, hand hygiene campaigns, medication safety, accreditation and standards. CAHO is leading the world in this. Medical emergency teams, a systems view. The whole system has to be taken into account. So there were 3 famous reports published in 2018. And those 3 famous reports were from the OECD and the World Health Organization and other important international bodies. And those 3 reports essentially said, we have to take a systems view of improvement. We have to think about how the system interfaces with other parts of the system and take a collaborative view. And that's what's happening more and more here in India, and it's happening more and more internationally, to take a systems view. So the question I have for you is, how will you get to 2030, whether you are optimistic or pessimistic? When I ran my poll, when I ran my survey of you, are you optimistic or pessimistic doesn't really matter. The question is, how do you get to 2030 and improve continuously across time on your quality improvement journey with the help of CAHO, with the help of all the expertise that is here in India to make quality better, but also the international expertise that my colleagues here represent. So the question is, and my slides still won't work, so it doesn't matter, I'm going to sign off now. The question is, how do you get to 2030? One answer is, my very good friend Dr. Anu has led a project at ISQA to look at quality and safety, but especially patient safety, in response to the World Health Organization's action plan, and it is being released at the moment, and it is an enormously useful document. So I recommend that to you, and you can see Dr. Anu here in the audience. Hi, Dr. Anu. And also Professor Ezequiel Garcia Alario, the president of ISQA, who can talk to you about this action plan of ISQA's for better patient safety, not just here in India, but across the world. So thank you very much. I think I managed to continue, even though my slides didn't work anymore. I hope, Professor Luckman and Professor Hibbert, your slides work better than mine. Thank you very much for your attention.
Thank you so much, Mr. Jeffrey. It was a pleasure to listen to you yesterday also, a beautiful interaction, and same here today, ultimately leading to some of the most practical thought processes for the people to work on. And now I request Professor Peter Paxson to please address the audience.
Wave if you can hear me at the back. Hello. Are the slides up? Okay, so I'm going to go race through some slides here to tell you about build on what Jeffrey has said. I'm going to talk about safety. What does the future hold? But first, got to start with the past. This is a quote that says, if you can't remember the past, you will never know the future, and you won't have a culture. And the timeline of patient safety, BJ was talking about yesterday, started even before Hippocrates with Hammurabi. And there you see the timeline that goes on up to right now, up to 2021, the Global Action Plan, which is the latest version of the timeline. And there you see the big reports to Earth Human in the UK at the same time, Organization of the Memory, and then the WHO report. But what's in that black box? I'm going to help you in the next 10, 15 minutes to tell you what's in the black box. We first got to ask three questions. Why is it important? What are the challenges? And how can we be safe? So first, why? If you don't know your why, there's no point in doing anything. The first big why are the people and their families who are the first victims. That's the first big why. And the world situation in 2018 said we harmed at least 8 million people in the lower middle income countries. Of course, that's the lower end. Those are the three reports that came out. And here are the other reports that came out, and the report, particularly in the upper income countries from David Bates, was a quarter of people were harmed in hospitals in Massachusetts, and that was really only 2 years ago. And of course, now we have the irrational taking away of international aid, and that's going to harm people. That's a patient safety issue. It's not only an aid issue. So that's the why. Quick through the whys. There's a compelling reason why. What are the challenges? The challenges are really of development. People change, they're dependent, they have different epidemiology, and then the social determinants of health. The 4 Ds. And I'm a pediatrician, so this is very important in pediatrics. And if you care of the elderly, very important care of the elderly, and those are the two extremes get affected. And what are the kind of things we have? This is for pediatrics, for example, medication safety, delayed diagnosis, infections, pain. The same applies for the elderly. But the big one right now is delayed diagnosis or different challenge in diagnosis, delayed, missed, or wrong diagnosis, and climate change. So diagnosis, climate change, and equity. Marginalized groups are really at risk more than those like you and me, maybe. So we really need to think about it. So remember, diagnosis, climate change, and equity are the 3 new big challenges in patient safety. So I've run through that very quickly because I wanted to get to the how in the next 10 minutes. And the how are very important. 10 hows, I think. The first is a culture. If you don't have culture, it's not going to work. So culture depends on your values, about having a vision, about relationships, respect, about courage. Courage to be safe, about compassion. The slides have gone. So, oh, there they are. It's working over there. James Reason, and I mentioned James Reason because he died a few weeks ago. He said there are 5 pillars. You have to be just, be informed, be flexible, have a reporting culture, and a learning culture. He said that many times years ago, and still holds. So in memory of James Reason, one of the fathers of patient safety, or safety in any industry, I put this slide up. So culture, remember culture. The next one is you have to learn and educate for safety. It's no point just having a culture, you have to have education for safety, because this is a quote from Eric Holnagel, that the variability that you do to job safety one day can cause and blame for safety incidents the next day. So people have to learn how to be safe. And you have to develop a learning system for safety. I adapted this from Glenn Elwyn and his colleagues who did this for quality. And I've created this for patient safety. And it's a very similar thing. You have to have a learning organization. Many of you may come from teaching organizations, but are you learning organizations? Patients of excellence are often not learning organizations. And how do you learn? That's very important to co-produce patient safety. And you have to learn from excellence, from what you do well, not only from what goes wrong. In the United Kingdom, we have a national body, just like air traffic, when you have an accident in aviation, there's a national body that investigates it. Here we have national bodies for learning, not to find out who did wrong, to find out what happened and how you can improve it. And Shin over there has that very similar in Japan, and you might hear about it later. I think Shin's going to talk about that. And then you have to educate for psychological safety. This is very important. You have to have continual learning, give people skills, create the culture, and what I call is you have to put it into the genome of every healthcare worker. What does that mean? If it's in the genome, in the DNA of every healthcare worker, doctors, nurses, allied professionals, then all they can do is patient safety. Currently, it's not in the genome. And that's our aim for the future. So that's learning. 3, you have to look after the healthcare workers. The well-being for safety. This is psychological safety. This is from Amy Edmondson, a definition from many years ago, 1999, but it only became fashionable in patient safety 2 or 3 years ago. That you don't punish people or humiliate them or blame. Very important. Burnout levels are very high. This comes from the UK. Burnout levels 50% and above. If you're burnt out, you cannot be safe. So you have to create well-being for safety, because burnout and poor well-being leads to higher safety incidents, as these reports show. So burnout is very second. And this means you have to look at the second victim. Remember I said the first victim? And this is a very good project we worked on in Europe across 27 countries. And you can access this online anywhere in the world to learn about the second victim and how to support them. So you have to support the first and the second victim at the same time. The fourth one now is you have to measure for patient safety. You have to measure at different levels. I'm going to show you different levels. This is international levels. This is a report from the WHO on the report that came out last year. In the previous year from Imperial College, the Global State of Patient Safety. You can log on to there and see where India is. It's very important. Again, Shin was involved very much in that one again. Or you can look at the local report. This is what came out this year And this is just showing you, focusing on children in the United Kingdom. And Jeffrey showed you how much it costs in the United States. In the UK, it's 5 billion. 5 billion. Can you imagine if they spent that 5 billion on healthcare instead of paying out compensation? And you can see 234 children in the UK die, but also maternal health. I know I'm very interested in maternal child health, and in maternity in the UK, there's a big problem of maternal well-being. So this comes out every year in the UK. So you've got to start doing this in India as well. And just shown down at unit level, this is where I worked at the Royal Free Hospital, how we got the number of days between children having a cardiac or respiratory arrest up to 170 to 200 days between each one. So this is at unit level and at Royal Free level. So it's national, international, national, and then at unit level. This is just some examples of how you can measure. So measurement. Then, of course, you have to design for safety. You have to make safety our business while we care for people. Not something we do when we have an adverse event, but this is what we do. And of course, it's the ability of this system to function under any condition, just like air traffic control, just like aircrafts. Of course, we're not aviation, but we have to try and do this in many different ways. And these are all the theories that you can apply. Jeffrey showed you some of the theories. This comes from the WHO. They have 7 chapters. You can delve into them. And I'll just highlight 1 or 2 of them. It's translating this into action. The most important thing is you think proactively, not retrospectively. It's like you can't drive your car only looking in the rearview mirror, which is a root cause analysis. You have to look forwards as well. You have to build reliable processes. You have to have human factors as the underlying part of any safety system. And you have to have resilience learning, often called safety 2. And to do that, you have to build safe teams. As I said, there are many different theories. This is team steps and crew management. You can choose which one you fancy. Doesn't matter as long as you choose one of them to build your teams. The core basis is the clinical team that is seeing the patients. And this is one I do in the UK, the SAFE, in which we have huddles where we identify patients who are at risk. We have the huddle, we mitigate, and then we escalate the care. And for reliability, this is the 5 tenets of high reliability, is thinking about safety all the time, preoccupied when things are going wrong, all the time. Really looking at it and deference to the expertise of the front line and not simplifying. And this is the SEEF model, which is the model of human factors made easy for clinical teams, how the clinical teams working with Pascal Carrion as the main thinker, and we apply this every day in clinical teams. And this you can apply in India very easily. And you have to ask, are we safe now, and will we be safe in the future? You have to embrace the future. I'm almost done. Embrace the future. The future is safe telehealth. And this is very important. And here are all the different things you have to think about telehealth. Safe AI. And that's going to be even more challenging because it's things that we haven't learned about yet. You have to co-produce safety and co-producing with patients. This is a document from the WHO last year. You have to aim to co-produce as giving up power to the patients so that they can be safe. You have to empower people to prevent, escalate, and investigate together. And finally, the real future of patient safety is the change in our culture. We cannot be safe if we do not change our culture, and safety must be in the genome of every healthcare professional. I hope I've helped you. Thank you very much.
I think an excellent roadmap to safety, which we, I think, keep on talking about. And now I request Dr. Peter Hibbert from Australian Institute of Health Innovation to please come for his talk.
So I'm going to talk about collaborative learning from patient safety adverse events, which is one of our, I suppose, key strategies when we're thinking about patient safety and how to improve. And Peter and Jeffrey have given a fantastic overview of some of the issues that I'm going to talk about. So when I think about patient safety, I always go back to the Institute of Medicine domains of quality. So when we're thinking about safety, we also should also have our eye on that for a high quality healthcare system. We need to think about effectiveness, efficiency, access, and all those different domains of care for a high quality health system. And we can measure, monitor and act on all of these domains at the level of our patients, at departments, hospitals, states, right up to the world level. So we can act on the system at various levels. A really nice summary of those domains is each patient should have access to the right care at the right time, safely, at the lowest possible cost, with their needs and preferences taken into account. And I think this gives us a really nice summary of why we go to work, why we're at this conference, why CAHO exists. So I think this is a nice summary or call to arms of what we're trying to achieve with our work. Peter's already alluded to this study, so this systematic review around the big studies around patient safety. It's basically summarised that 12% of hospital admissions are related, have an adverse event, and 5% of those are preventable. So if we're talking in our countries, we're talking about hundreds of thousands of adverse events, and we're talking about tens of thousands serious adverse events. Behind the numbers, there's always people. And there is intense media and societal interest in patient safety and adverse events. And so there should be, because I think in terms of accountability of us and our healthcare organisations, it is important that these stories are out there. But it is important that there are real people behind each of these stories that we're talking about today. When there's a serious adverse event, that organisations have obligations around responding to these serious adverse events. The first thing they need to do is try and prevent the same incident occurring again. And we generally do this through error disclosure, incident management, and also undertaking investigations. And when we're undertaking investigations, we're trying to understand what happened and why, and how can we stop that happening again. The system is not working very well, which I'll be talking about in the next few minutes. We need to talk to our patients and families, and we need to be open and honest about what happened and why, and what the organisation is doing to stop this happening again. We need to support our traumatised families and patients, but also thinking about our second victim as staff. A serious adverse event can be the worst thing that ever happens to one of our staff. It can compel them to leave your organisation or even leave the profession. So supporting those staff and using the principles of restorative just culture are crucial. Organisations need to have assurance to the CEO, to the board, the minister, and importantly to model that safe and just culture. So it's very easy to put in a policy or procedure that we have a no blame culture, but actually when a serious adverse event occurs, it really challenges our organisations to continue to model that safe and just culture. So if we're thinking about patient safety investigations and error disclosures, we know from the research though, even though there's a lot of activity, they're not that effective in terms of reducing harm to patients. So the research really is around that there's not a lot of improvements to patient care from our incident management and investigation methodologies. So we are doing some research in this area. Jeffrey and I are leading this research in Australia to really try and understand how we can improve our safety investigation methodologies. And I'd like to talk to you about 3 different directions that the research is going. It's more complex than this, but I just want to concentrate on 3 things. So the three things really are around consumer representatives on investigations, undertaking system-level analysis. Peter mentioned this in relation to SEEPs, and then really a challenge around how we're spending our safety and quality resources in terms of whether we should be doing investigations or actually implementing what we know works. So the first thing I'd like to talk to you about, the first thing is the consumer representatives on investigation teams. We know that CAHO has been really instrumental in helping organisations put in patient advisory councils, and now there's a patient safety foundation, Patient for Patient Safety Foundation in India. So that's all fantastic, and this work that we're advocating around putting consumer representatives on investigation teams is an extension of that. So when there is an error disclosure or when there's an investigation, what a consumer representative does, it brings that consumer perspective to the discussion. They provide that independent view, they advocate for the patient to remain central, and they really help address some of the community expectations around public oversight and accountability. We are doing an evaluation of this in Australia. So one of the public health jurisdictions now is consumer representatives on most of their investigation teams. So it's been a real game changer in Australia about how we manage our adverse events. The second thing I'd like to talk about is collaborative organisational systems level analysis. This is typically how incident data is presented. Okay, so within our organisations, so we see typically we've got adverse event types down one side. We've got how severe these incidents are. But in terms of for the organisation, it's not meaningful. They can't really action it. They don't really know what to do with this type of data. This is the number of incidents reported every year in an organisation with an electronic reporting system and a mature reporting culture. What we're kind of advocating is looking at more of a systems level approach, so aggregating multiple incidents together, incorporating the perspectives of clinicians, incorporating patient stories, and really trying to understand what are the big organisational factors that impact on the way clinicians work. And this is much more likely to deeply engage senior executives, boards and clinicians. So some of the work that I've done with an ambulance service in Australia, we looked at only 14 serious adverse events. We did a big incident analysis, an aggregated review of those incidents. All of those incidents related to underappreciation of clinical risk or delayed diagnosis. And what that showed was when we mapped out all the contributing factors into what we call an axi-map. And what an axi-map does is looks at the contributing factors very much at the ground level. It looks at the contributing factors at organisational level and even external factors as well. And essentially this transformed the organisation's thinking and culture around patient safety, because what it did, it mapped the contributing factors at the organisational level. So things like the KPIs that the organisation was using, so a focus on non-clinical targets and a compliance culture, and it directly mapped how that organisation was working at an organisational level to those adverse events. And really it was the starting point for a deep conversation around patient safety and a transformation around how they manage their patient safety. We see a lot of this work across different organisations in the world. Peter mentioned HSSIB in the UK, but we're using a lot of organisations across the world. Again, SHIN is one of these organisations that map the key issues around patient safety across the world. The last thing I'd like to talk about is where we're focusing our safety and quality efforts, and really talking about, should we be doing more patient safety investigations or should we be implementing what we know works? And I'm going to use the analogy of a soccer or hockey field. Sorry, I couldn't use a cricket analogy. I think that would have worked better, but I'm going to use a soccer one. So this is from Salford Royal. They use this analogy in the UK, and it really talks to, we're really asking that question, are we spending the right resources on what goes wrong versus improving the system? So we think about sport, we think about hockey or soccer, that when we want to win a game, we need to stop the opposition scoring goals. We need to score goals ourselves. When we're thinking a lot about the work that we do in patient safety, it's about incident analysis, investigations, risk management, those sorts of things. And can we think about that in terms of defence and stopping bad things occurring? But it's not actually going to win us the game and improve our healthcare system. We need the offence as well. There are some critical things, interventions, that we know works. We've got really good evidence around improving safety culture, having high-functioning, resilient teams. So Peter talked about team steps and CRM, structured handovers communications, rapid response teams, co-design with consumers, IT systems with decision supports. So these are the interventions that have got quite good evidence around them. And I think probably from a clinical governance perspective, we're probably, most of the organisations that I work with, probably spending a little bit too much time on managing incidents retrospectively, undertaking investigations retrospectively, rather than doing these things that we know works. So the three questions to finish off for me are, how do we bring the patient voice to learning from adverse events? Are we taking a strategic systems-based learning approach? And are we getting the balance right between retrospectively undertaking investigations and implementing what we know works? Thank you.
You know, the overall aspects of quality, safety, I think this is something which is understood by all of us. You know, if we ask after the end of these sessions, we ask the audience, all of us sitting over here, do we know about it? Most of us will answer, yes, we know about it all. If we ask the audience again, because most of us sitting over here, they are senior leaders, they are quality professionals, and when you ask them, do we want to do it, we ought to act upon it, they all say, yes, we want to do it. Now the question is to act upon it. And this is a time to act. And when the time to act comes, these are obstacles, and these are the challenges. And that's exactly the same three gentlemen were there as experts yesterday on the leadership pre-workshop that we had at Venkateshwar, talking about obstacles and the challenges which come in implementation of that. And gentlemen, thank you so much for giving the solutions. I think each one of us sitting in this room, whether a large organization or a small organization, we all want to do it. We all know that it has to be done. Ultimately, what was said, that we embrace the future for the vision of quality and safety, I think we need to move forward. And that's where I think the advice that has come up today. Thank you so much for bringing out all the relevant points, which can be probably implemented in all the organizations at various stages of evolution to make the question where we started, 2030, are we looking at that as the time when we are able to achieve the safety? I think 2030 and beyond, lots going to happen with the support like that and advice like that. Thank you so much, and thank you for the wonderful audience.